This is a study that came out recently in obesity surgery, just from this month, which is September 2011, which compared various authors that compared different surgeries with each other. And these were prospective randomized studies. So these are the higher quality studies that have ever been done to compare these surgeries. Unfortunately, not all three next to each other, but different surgeries against each other. And so this is a nice table summary. I won't go into too much detail. It'll be there for your reference on our website, and from different countries as well. Dr. Nguyen from here in the US and California looked and compared gastric bypass, Roux-en-Y's gastric bypass, to AGB, adjustable gastric band patients, and then showed his data for weight loss, excess weight loss at a year and 3 years. Jacques Himpens from Belgium compared adjustable gastric band patients to laparoscopic sleeve gastrectomy patient. LSG is laparoscopic sleeve gastrectomy patients, and his results at a year and 3 years. Angrisani from Italy that compared the adjustable gastric band to the Roux-en-Y gastric bypass, and his results at a year and 3 years. Karamanakos from Greece, which compared the sleeve gastrectomy and the gastric bypass, and his results at a year. Langer in Austria that compared the adjustable gastric band with the sleeve gastrectomy. Unfortunately, his results went 3 months and 6 months, so here is his 6-month data. And Petrilli in Switzerland, who looked at the laparoscopic sleeve gastrectomy and the gastric bypass. So you can review that in more detail. But basically, it tells the story of a lot of variability in depending on which two surgeries were compared, and I think the data is very interesting to look at. Next, I want to shift our focus a little bit on what we've been able to accomplish as a society, as a group of surgeons, as a group of healthcare providers, not just physicians, and not just bariatric surgeons, but all physicians and nurses and allied health personnel and all the people who support our patients all over the world, and focus on what a tremendous job we've done as time has gone on and the quality of care we've been able to provide this patient group and the outstanding things we've been able to accomplish with our patients and for our patients. So this is a study that was in the longitudinal assessment database called Longitudinal Assessment Bariatric Surgery. And this was a study about perioperative safety, the time around surgery. And it was published in the New England Journal of Medicine in July of 2009. Looked at about 5,000 patients who had first-time bariatric surgery, and the overall mortality of risk to life at 3 in 1,000, which is just outstanding, with all the patients from all risk put all together. And the conclusion of this study, and it was a very important one, is that the overall risk of death and adverse outcomes was low. Next, I want to look at the BOLD database. BOLD is the database that we use in Centers of Excellence for bariatric surgery. And BOLD stands for Bariatric Outcomes and Longitudinal Database. And this was published in 2010. The first 58,000 patients who were enrolled in BOLD between June of 2007 and May of 2009. The breakdown of the procedures were that about 55% of patients had gastric bypass, about 40% had gastric bands, the sleeve was done in about 2%, and the duodenal switch is done in just under 1%. The complication data is quite remarkable. This was people who had at least one complication, and it includes both minor complications as well as major complications. So in the gastric banding group, about a 4.6% likelihood of complication. Sleeve gastrectomy, about 10.8%. Gastric bypass, about 14.9%. And duodenal switch, about 25.7%. And mind you, this data reflects one complication, however minor, even if a patient reported nausea, that was considered a complication. So this data is even more remarkable if we consider that. Mortality, if we put all the patients together, 1.3 per 1,000 over the whole period of time the patients were studied. If you look at the 30-day mortality, which is what we really tend to focus on in healthcare and in medicine, and that's less than 1 in 1,000. It's 0.9 per 1,000, or 9 in every 10,000. So it's really a remarkable testament to the job that we're all doing. We look at life expectancy data. This is a study from Canada that compared people who had bariatric surgery and those that were matched but did not have surgery. And they look at the 5-year death rate in the bariatric surgery group at 5 years, it was found to be 0.68% in 5 years for the people who had surgery. And at 5 years, that same group of medical patients, the death rate was 6.1%. So surgery was able to achieve an almost 90% relative risk reduction for mortality in bariatric surgery patients. This was an important paper that was done in Utah that looked at long-term mortality after gastric bypass surgery. And they took 8,000 patients who had gastric bypass and 8,000 patients who were matched up to be as obese, and they followed them out to 7 years. And what they found that in gastric bypass patients, mortality decreased by 40% in those patients who had surgery compared to those who did not. If you looked at specific causes, the decrease is even more remarkable. For people who had heart disease, a mortality decrease of 56% in gastric bypass patients. For diabetic patients, 92% decrease in mortality. For patients who had a history of cancer, a 60% decrease in mortality. So this is truly amazing information. This is a study that looked, it was we call a meta-analysis, large review, that looked at bariatric surgery, and this was from 2004 in the Journal of American Medical Association. And this looked at 22,000 patients who had bariatric surgery. And the overall excess weight loss, if you put all the patients together with all the different surgeries, 61.2% excess weight loss. Even more remarkable, the conclusions of the study. Looking at patients with diabetes resolved in 76.8% of patients. It resolved or improved in 86% of patients. In patients who had lipid problems, like high cholesterol and bad cholesterol, 70% of the patients improved with surgery. For high blood pressure or hypertension, it resolved in 61.7%. It resolved and improved in almost 80%. And for sleep apnea, it resolved in 85%. It resolved and improved in almost 85% of patients. So we're going to shift our focus a little bit now onto what's very much hot in medicine and hot in the news, and that's the effect of surgery and better treatments for type 2 diabetics. So this is a study from fairly recently in the American Journal of Medicine, which looked at weight and type 2 diabetes after bariatric surgery. They looked at it was a meta-analysis paper, so they reviewed 621 studies that detailed 135,000 patients. They identified 103 different papers that dealt with 3,200 patients that had reported information on the resolution of diabetes. And the overall conclusion was that in those patients, 78.1% of the patients had resolution of their diabetes. Diabetes improved or resolved in 86.6% of patients. The other conclusion of the paper was that weight loss and diabetes resolution were greatest for duodenal switch patients, followed by gastric bypass patients, and followed by and least for gastric banding patients. There was a study, again, that was from very recently, this year, 2011, that showed the efficacy of gastric bypass and compared it to medically managed control patients using the American Diabetes Association endpoints for 3 very important things for type 2 diabetics. And that was how well they controlled their glucose or sugar with watching their hemoglobin A1Cs and wanting that to be less than 7%, their bad cholesterol, their LDL being less than 100, and their systolic blood pressure being less than 130. And it looked at 150 or so gastric bypass patients and 115 medical patients with conventional medical therapy. And the conclusion was that there was a significant decrease in the body mass index in the gastric bypass patient. And looking at 2 years, the gastric bypass patients demonstrated increased achievement of the American Diabetes Association goals compared to the medical patients. This was a study done in Australia. It was a randomized trial comparing conventional medical therapy and patients who had adjustable gastric banding in Australia for patients who had type 2 diabetes. It looked at 60 patients that were randomized with a body mass index between 30 and 40. And the conclusion was at 2 years that the remission of type 2 diabetes in the surgical group was 73%, and in the conventional or medical group it was 13%. This was a very, very important thing that happened about 2 months ago in June of 2011, when the International Diabetes Federation issued its first ever statement or commentary commenting in any way about type 2 diabetes and about the role for bariatric surgery. And it was released in 3 journals recently: Diabetic Medicine, the position statement from the International Diabetes Federation, as well as in our American Obesity Journal, the Society of Obesity and Related Disease Journal. And the conclusion, the executive summary conclusions for the IDF statement was that surgery should be an accepted option in people who have a BMI over 35 and type 2 diabetes, and that it should be considered strongly as an option in patients who have a BMI more than 30 but less than 35, so the lower BMI group, the 30 to 35 or class 1 obese group, when diabetes cannot be controlled by conventional treatment. And that's a hemoglobin A1C of over 7.5, and especially in patients who have cardiovascular disease or similar diseases that present risk, like lipid problems or sleep apnea patients or patients who have high blood pressure. The statement, an executive statement, goes on to say that in Asian patients and potentially even in other certain ethnic groups, BMI points and requirements may need to be reduced by as much as 2.5. So instead of looking at 35 to 40 group, we might be looking at 32.5 to 37.5, and in that 30 to 35 group, we might be looking at 27.5 to 32.5 BMI. It also made a statement that the available evidence indicates that bariatric surgery for obese patients with type 2 diabetes is cost effective, and that the morbidity and mortality associated with surgery is generally low, and it's similar to that of accepted procedures such as elective gallbladder surgery. So my surgical experience: I've performed almost 1,000 bariatric procedures in my career, 918 through July of 2011. Gastric bypass, 618 procedures. Sleeve gastrectomy, 39 procedures. Adjustable gastric banding, 154 procedures. And revision procedures, 107. In my practice, I offer adjustable gastric banding, sleeve gastrectomy, gastric bypass, as well as revision procedures. And we do almost all of our procedures laparoscopically or with a minimally invasive approach. So what would be the next steps? You can call my office to set up a consultation appointment. We have 2 office locations, Seattle, as well as on the east side in Kirkland. You can visit the website at northwestobeసిtysurgery.com. There are educational videos, animation videos, there are surgical videos, there's more background information about myself, lots of great links. You won't find a lot of before and after type of things on our website, but you will have the ability to connect to, for example, obesity help and read the blogs that our patients have posted, as well as get a lot of evidence-based information. I certainly want to thank everyone for their attention. We're happy to stay around as long as necessary to answer any questions as it pertains to anything that anybody came with tonight. And I very much thank you and I appreciate your attention. Thank you very much.